Hello and welcome to BLC Prep 006, the surgery section part 2. In this module, we'll be going over the respiratory system, the hemic, lymphatic, and the mediastinum and the diaphragm, and also cardiology. We're going to begin talking about the respiratory system. The diagram here includes all of the body parts or body areas or organs that are associated with the respiratory system. The anatomical site arrangement would be the nose and the larynx. If you look in your respiratory system section in your CPT book, you will see that each anatomical site is further subdivided by the procedure. Was there an incision done to that site? Was there an excision done to that site? You should find all of your sections like that by procedures. One of the most common procedures you'll see in respiratory coding are endoscopies. There are some rules when you're coding an endoscopy. Rule 1, excuse me, you want to code to the full extent. Excuse me, the procedure begins at the mouth and ends at the bronchial tube. That means when you're looking at your endoscopy report, that the provider should have documented that the endoscope, was inserted through the mouth, and he should have some type of reading or documentation where he viewed the bronchial tube. If that has been done, that is to the full extent. Rule 2, code correct approach. The example, if they're going in for a removal, if they're removing an interior lung lesion via the endoscopy, it's inserted through the mouth. If they may do an exterior lung lesion removal via endoscopy through the skin. The incorrect approach could give you the incorrect code, which also could lead to incorrect reimbursement. Rule 3, diagnostic always includes surgical. Example, that they start off with the diagnostic endoscopy, they identify a foreign body, and then they remove it. That becomes a surgical endoscopy. All of your procedures will be that way. If they do a diagnostic procedure, if they're doing a diagnostic procedure, they really don't know what's going on yet until they get inside and see what's going on. Not always will they find anything. Say that they did EGD and they didn't find any blockage or anything like that. It was a diagnostic, EGD. But if they went in and they found polyps or some other lesion or anything and they removed it, it then became surgical. If it begins as a diagnostic and some type of surgical procedure is done, you're only going to code the surgical procedure. Multiple procedures are frequently in the respiratory coding section, so watch for your bundled services. You always want to sequence your primary procedure first with no modifier, and then any secondary procedure with modifier 51. In the respiratory section, you'll see a lot of bilateral procedures are often performed. Format for reporting is basically by payer. Because some payers, like if they had a nasal lavage, some payers may want you to put 31000 times 2, or they want you to put 3100 with the modifier 50, or just the code with the modifier 50, or RTLT. For coding purposes and certification purposes, you will be using the modifier 50 based on coding guidelines. However, when you get into a real-world coding position or billing position, it just depends on the payer what modifier they want. Laryngoscopic procedures. They use terms like indirect and direct. An indirect laryngoscopic procedure is when they use a tongue depressor with a mirror to use to view the larynx. A direct is when an endoscopy is passed into the larynx and the physician directly views the vocal cords. The next part of the respiratory system is the nose. And again, you can see the This category goes from 3000 to 30999. Here you have your different areas of procedures that are considered part of the nasal area, the nasal septum, the dorsal nasi, the bridge, the root, and so forth. For an incision into the nose, your code is going to be either 3000 or 30020. This section is used extensively by ENTs or otorhinolaryngologists. Can never say that word correctly, so we always call them ENTs. But a variety of physicians can also use these codes. When there's an approach to the nose, an external approach, if they're doing outside of the nose, you're going to use your integumentary system codes. Your internal approaches, you're going to use your respiratory system codes. Bundled into incision codes are drain or gauze insertion and removal, so you would not code for those separately. Supplies, you would. So an excision nose, this is where you'll find codes for biopsies, polyp excisions by complexity. The excision includes any method of destruction, even laser. So if they're putting their cryotherapy by laser, that's included with the code, so you would not code that separately. And again, you would use modifier 50 if they're doing both sides. Any introduction in the nose, your range of codes is going to be 30200 to 30220. Some common procedures in this section are injections to shrink nasal turbinate tissue, displacement therapy, which is a saline flush, which is performed through the nose to remove mucus, and or insertion of a nasal button. So some of your other categories, 30300 to 30320, are removal of any foreign body to the nose, any repairs to the nose. Your range of codes are going to be 30400 to 30630. Any destruction, 30801 or 02. So if they're doing a removal of foreign body, it's divided by whether the removal was done at the hospital or at an office, which the hospital, they would require general anesthesia. Under the repair, you're going to find a lot of your plastic surgery, your rhinoplasties, which is the reshaping of the nose, internal and or external, or septoplasty, which is the rearrangement of the nasal septum. Under the destruction, you're going to find codes for use of cauterization or ablation, removing by cutting. Used also for removal of excess nasal mucosa or to reduce turbinate inflammation. Under the destruction, it is based on intramural or superficial extent of destruction. Intramural, that means they're in a deeper mucosa. Superficial is the outer layer of the mucosa. I've coded a lot of these, and they will be they're pretty usually well documented, whether it's intramural or superficial. Other nose procedures, your range of codes are going to be 30901 to 30999. Here you will find your codes for nasal hemorrhages, or and that's spelled wrong. You need to correct that. Nasal hemorrhages, this is where you'll find your nosebleeds for the packing, ligation, or cauterization. Your anterior packing is placed through the nose, and your posterior packing is placed at the very back of the throat. Your accessory sinuses, your incision, excisions, and endoscopies, your range of codes are going to be 31000 to 31294. Here you will find codes for lavage, which is washing of the sinuses. This is where a cannula is placed into the sinus and saline fluid is flushed through. If they do both sides, you want to append modifier 50. For an excision to the larynx, your range of codes is going to be 31300 to 31420. Here you will find your laryngotomy, which is an open surgical procedure to expose the larynx for such as removal of a tumor. It is sometimes confused with the trachea-bronchia codes for tracheostomy, which is used to establish airflow. Any introduction into the larynx, your range of codes are going to be 31500 or 31502, and this may be an endotracheal intubation to establishment of the airway. Any repair to the larynx, your range of codes is going to be 31580 to 31590. You have several plastic procedures and fracture repairs in this section. The laryngoplasty procedures are based on the purpose. Any incisions into the trachea or the bronchi, your range of codes are going to be 31600 to 31614. Most codes, this is where you're going to find your tracheostomies. There's only really two codes, whether it was planned or it was an emergency trach placed. It is divided by type, was it transtracheal or cricothyroid? And again, your surgical or op report will usually identify whether it's transtracheal or cricothyroid. So endoscopies for the larynx is a bronchoscope, which is inserted through the nose or the mouth. A rigid endoscopy is performed under general anesthesia. A flexible endoscopy is performed under local or conscious sedation. So any introduction into the trachea or bronchi, your range of codes are going to be 31715 to 31730. Here you will find your catheterizations, your instillations, any injections or aspirations, trachea tube placement, and some include inhaled gas as a contrast material. So you would not code for that separate as well. So your excisions to the trachea or the bronchi, your range of codes or repair is going to be 31750 to 31830. Here you're going to find your tracheoplasties and your bronchioplasties. We're going to move over to the lungs and pleura, and as you can see, they start all over with what type of procedure. So for an excision, you're going to start off with 32421 or 22. Here you may find your thoracentesis, which is a needle that is inserted into this pleural space for aspiration. Also in this section, you may find a chest tube insertion, which is inserted to drain fluid and is reported in addition to the aspiration. And 32035 to 32225, you'll find your thoracotomies, which is a surgical opening of the chest exposed to view the chest. It can be used for a biopsy, removal of a cyst, removal of a foreign body, or a cardiac massage. Your range of codes 32310 to 32405. Here where you're going to find your biopsy codes. Your biopsy codes in excision and incision categories. An excisional biopsy is done with a percutaneous needle. An incisional biopsy is done with the chest open. Any procedures are removal of the lungs and the pleural. Your range of codes are going to be 32420 to 32540. In this section, you will find your pneumocentesis and lung removals. If they're doing a segmentectomy, they're only removing one segment of the lung. If they're doing a lobectomy, they're doing one lobe. If they're doing a bilobectomy, they're doing two lobes. If they do a total pneumonectomy, they're removing the entire lung, the one lung. So that kind of sums up your respiratory system. We're going to move now over to our hemic and lymphatic system subsection. In this section, you're going to have it divided in three under the spleen, general lymph nodes, and lymphatic channels. So for procedures done on your spleen, your range of codes are going to be 38100 to 38200. The spleen is easily ruptured, which causes massive hemorrhaging, which may require a splenectomy. The splenectomy may be a total or partial, and it is often done as part of a more major procedure? If so, it's bundled into that major procedure. Then your codes are divided based on whether they're doing a aspiration, biopsy, harvesting, or transplantation. Your range of codes here are going to be 38204 to 38242. Stem cells, which are immature blood cells originating in bone marrow, and they're used for leukemia treatment. The type of stem cells are allogenic, which is from a close relative, or autologous, which is the patient's own. Procedures done on the lymph nodes and the lymphatic system, your range of codes are going to be 38300 to 38999. There's two types of lymphadenectomies. A limited lymphadenectomy, they're only going to remove the lymph nodes. A radical, they're going to remove the lymph nodes, the submandibular gland, and any surrounding tissue. Your lymphadenectomies are often bundled into more major procedure like a prostatectomy. Do not unbundle and report it separately. When we're saying that these are surgical procedures, but they're often done at the time of a more major procedure, and if they're done, you would not code them separately. That's what they're saying when they're talking about bundling. Procedures done on the mediastinum. Your range of codes here are 39000 to 39499. There's only two sections, I believe. There's incision codes and excision codes. Your incision codes may be a foreign body removal or a biopsy. Your excision codes may be for removal of a cyst or a tumor. For procedures done on the diaphragm, your range is 39501 to 39561. Only category in this section is repair, and most codes are for hernia or laceration repairs. And again, I've also added, I thought, some good illustrations. And do remember, what I would do is kind of tab your illustrations in your CPT book so that when you're coding something, you can kind of look at the illustration and see what part of the body, where are the common, organs that are close to that body. So if you're looking at an op report and you see something that you're not really sure what part of the body that is, you can those illustrations in your CPT book are really good. And then also I've added some here throughout the presentations. So now we're going to move over to the most tedious section. I'm not a big fan of coding cardiology. As you can see, there's a lot of arteries and veins. It is a very, I think it's very complex. I've coded them before, but I will admit it's not my favorite area to code because it's very, very complex. But cardiovascular coding may require codes from different sections of your CPT book. You will find cardiology procedures under your radiology section, which are usually your diagnostic studies, in the medicine section, which are usually your non-surgical or percutaneous procedures, and then in the surgery section, you're going to find open procedures and percutaneous procedures. So let's talk about some terminology. Invasive, I think we talked about this. That means enters the body. An example here is opening the chest for removal of a tumor on the heart or a percutaneous placement of a catheter in an artery. Both the medicine and surgery section do contain invasive procedures. A non-invasive procedure is one that does not break the skin, such as an EKG or electrocardiogram. And the electrophysiology EPS is the study of the electrical system of the heart. They have separate EPS departments that do these types of studies. So you may have a cardiologist, and then you may have an EPS department, and they do code separately. When they're doing a study of the electrical system of the heart, an example may be the study of an irregular heartbeat for arrhythmia. Nuclear cardiology, these are diagnostic and treatment specialties where they use radioactive substances for cardiac conditions, example like an MRI. All right, cardiovascular in the surgery section. Now, these procedures all are going to be found in your surgery section. So, for the heart and the pericardium, your range of codes are going to be 33010 to 33999. Here, you're going to find procedures for your pacemakers, your valve disorders, any procedures done on the artery or the veins. Your range of codes are going to be 34001 to 37799, but many of the same types of procedures, but non-coronary procedures. They're both contain percutaneous and open surgical. There are extensive notes and guidelines. Remember, I always say go back to the beginning and read all your guidelines. There's a lot of coding rules that will help you, and it does change frequently with all the new medical medical advances. So, the heart and the pericardium, your range of codes 33010 to 33999. Example, some of the subheadings here are procedures done for the pericardium, a cardiac tumor, a pacemaker or a pacing cardioverter defibrillator. Your categories you may see is pericardiocentesis, which is a percutaneous withdrawal of fluid from the pericardial space. Or you may find excision of a cardiac tumor, which is an open surgical procedure for removal of the tumor on the heart. Your pacemaker codes are going to be 33202 to 33249. These are devices that assist in the electrical function of the heart. Here is a kind of an illustration of the actual pacemaker. In this section is divided by where the pacer is placed, the approach, and the type of service. So a pacemaker can be placed in the atrium, which is a single chamber. The ventricle is also a single chamber. If it's both, that's what they consider a dual chamber. Biventricular is both ventricles in the right atrium, and they use at least 3 leads. The approach, it could be done either epicardial or transvenous. Epicardial is an open procedure to place on the heart. Transvenous is through a vein to place in the heart. The type of service, is this the initial placement or the replacement of all or part of a pacemaker, or just the leads being replaced, and how many are the number of leads are being replaced. The patient's record indicates either it's a revision or a replacement. The usual global period or follow-up period would be 90 days. If they have to return to the operating room within that 90 days to, adjust the defibrillator, redo something, you would use your modifier 78, which indicates the return to the operating room. Your electrophysiologic procedures are, your range of codes here are going to be 33250 to 33266. Normally the chest is open to full view, so which is going to make it an incision. Cardiopulmonary bypasses are usually used. The surgeon is actually repairing a defect causing the abnormal rhythm. If it's done with the endoscopy without the cardiopulmonary bypass, codes are based on the reason for the procedure and approach, and if a CP bypass was used. Patient activated event recorder 33282 and 33284 is also known as a cardiac event recorder or loop recorder. It's surgically implanted, and its code is divided based on the device being either implanted or removed. So you have one, either they're going to implant it or they're removing it. Procedures done on the cardiac valves. Your range of codes here are going to be 33361 to 33496. They're divided based on the valve and the cardiopulmonary bypass. It could be the aortic, the mitral, the tricuspid, or the pulmonary. A lot of the code descriptions are similar, so be very careful when you're selecting codes. One, you will hear verbiage or word you will hear a CABG, which is a coronary artery bypass graft, but you will always hear them called a CABG. These are performed on the coronary arteries that are severely clogged. They have atherosclerosis. Your range of codes here are going to be 33500 to 33572. And this illustration, again, I know a lot of people always say, like, what do they do it? What is atherosclerosis? And I thought this was a really good illustration. A normal artery here being at the top, fatty streaks, plaque, and then when they have full atherosclerosis, you see how narrow the blood is, able to get through. So that's the reason why they do that. So when they're doing a CABG, you have to determine what was used to repair it. Was it the vein? If it was a vein, your range of codes are going to be 33510 to 16. Was it the artery only? 33533 to 36. Or both the artery and the vein, which your range of codes could be 517 to 523 and 533 to 510. The number of bypass grafts performed, and if vein and arterial grafts are used. Those are usually, when they first started doing them years and years ago, they were very difficult, kind of hard, but now the op reports are pretty self-explanatory. I know it seems like a lot, like which artery, how many veins. Usually the doctors, they document this pretty well, so you're really able to go in and say, okay, did they use the vein? Did they use both? And so forth. Example here, they did 3 venous grafts. So your arterial grafting, again, your range of codes are 33533 to 33536. They are divided based on the number of grafts. Several codes, 33542 to 548 for myocardial resection, which is repair of a ventricular septal defect and a ventricular restoration procedures. Obtaining an artery for our grafting is included in the codes, except if they're procuring an upper extremity artery, like a radial artery, then you would code it separately. So basically, if they're obtaining an artery from an extremity or a major extremity or a femoral artery or something like that, you would code that separately. So if they're doing the artery and the vein, which is combined arterial venous grafting, your range of codes are 33517 to 523, again divided based on the number of grafts. Any procuring of the saphenous vein is included. If open retrieval, that means if you see that they're procuring the saphenous vein, you would not code for that separately. It's included with that code. Endoscopic harvest, however, is reported with 33508. So if you see that it was an endoscopic harvest, you can report that additional code. If it's a reoperation, you want to report 33530 with no 51 modifier add-on. This is never used alone and is always used with arterial grafting codes. And arterial venous codes report only venous graft portion of the procedure. And you guys can kind of see why I don't like doing cardiology, because it's so much. You got to learn, really have your A&P down, or your anatomy of your heart and artery and veins. So endovascular repair of the descending thoracic aorta. Your range of codes here is going to be 33880 to 891. This may be placement of a prosthetic for repair of the descending thoracic aorta, or synthetic aortic prosthesis, which is placed via a catheter. These are less invasive than chest or an abdominal incision. If they do it with fluoroscopic guidance, you can report that separately using your radiology codes 75956 through 59. It does include diagnostic imaging, both preoperative and intraoperative. So if you see diagnostic images documented, those are also inclusive. If they've taken imaging through the surgery and you see that document, that is also included in the code, and you would not code for that separately. If they place a stent or a graft, which they also call the endoprosthesis, this reinforces weakened areas. Your arteries and your vein subheading, these are your procedures here. I'm not real sure, guys, why my pop-ups are kind of backwards tonight. Sorry about that. But your arteries and vein subheadings, your range of codes here are 34001 to 37799. This section is only for non-coronary vessels. They are divided based on whether artery or vein is used. The example here, there are different codes for an embolectomy depending on the artery or the vein. Catheters that are placed into the vessels for monitoring, removal, or repair. You're using a non-selective or selective catheter placement. Again, your documentation should, the providers have gotten really better with documentation of cardiology procedures, so you should not, just may have to read through a lot. But non-selective, this is where it's a direct placement without further manipulation, and means they're not advancing that catheter anywhere. They're at the point that they need to see or repair. Or selective is where they place the catheter and then they manipulate it into further orders. The example here, non-selective, is an introduction of a needle into a vein. It's going directly into a vein. Selective would be 36012, which is placement of a catheter into a second-order venous system. And when we come back for our live lecture, we'll discuss this again, because I think I told you guys about interventional radiology. That's one of the that kind of goes hand in hand with the cardiology section, and we'll talk about that, and we'll talk about the different orders, and I'll show you guys my famous tree that I usually draw. And they have one here on the slide, but I like to draw my own. But just to kind of tell you what it is. All right, so we do. I won't draw it. We already have one. But as you can see, vascular families are like a tree. So the main branch is your first order, which is your tree trunk. So we're going to look at it right. Here's your trunk. And then the second order may be a tree limb, which is kind of, branches off. And then your third order may be a tree branch. So it's like what they do, and again, I'm not in Electa Live, so I don't have my marker available, but basically what it is, they will insert a catheter and say that they're trying to get here to the external carotid artery, where they're going to go in through the brachiocephalic artery first, and then they're going to manipulate the catheter up into the branch or the tree limb. And then they're going to further manipulate the catheter to reach the external carotid artery, which is the third order. So there is an appendix in your CPT of vascular families, which lists first, second, and third, and beyond third order branches. Again, long time ago, we didn't have that information, so this was a big plus that they added. Assumption, though, is that their starting point is the catheterization of an aorta. So it has to be, for you to use that grid, it has to start, that tree trunk has to be the catheterization of an aorta. The brachiocephalic vascular family, you want to report farthest extent of the catheter placement in a vascular family. Embolectomies and thrombectomies, your range of codes are going to be 34001 to 34490. Embolus is a dislodged thrombus. A thrombus is a mass of material in a vessel in place of formation. It can be removed by balloon method, where the balloon is threaded into the vessel, inflated under the mass, and then pulled out with the mass. Your venous reconstruction, your range of codes here are 34501 to 34530. The types of repair in this section could be valve of a femoral vein, the vena cava, the saphenopoplatal vein anastomosis. Also, you will find a section for aneurysms. Aneurysm is a ballooned or weakened area of a vessel. It is repaired by either removal, bypass, or coil placement. If they do a coil placement, it's a tiny flexible platinum coil which is pushed into the aneurysm and forms a ball to obstruct blood flow into the aneurysm. If it's done by endovascular repair, your range of codes are going to be 34800 to 900, which is done from inside the vessel. If it's direct repair, it's going to be 35001 to 152, which is from outside of the vessel. If you are coding repair of an abdominal aortic aneurysm, there are extensive notes in your CPD preceding. You must read those guidelines. Again, if they're using fluoroscopic guidance when they're doing this repair, you can report that fluoroscopic guidance with your radiology codes. Endovascular repair, this includes the access, catheter manipulation, a balloon angioplasty, stent placement, and site closure. Any procedures performed at the same time can be coded separately. This section here, repair of a arteriovenous fistula. Your range of codes are 35180 to 190. Fistula is abnormal passage. It's divided based on the fistula type. Is it congenital? Is it acquired or traumatic? And by site. Your angioplasties and your atherectomies, your range of codes are going to be 35450 to 35495. They can be either done open or percutaneously by vessel. Transluminal angioplasty is where the catheter is placed into the vessel and stretched. If they are placing a stent, you can report that separately. A transluminal atherectomy is a guide wire that's threaded into the vessel where the clots are destroyed. Your non-coronary bypass grafts are going to be, your range of codes are going to be 35500 to 35671. Again, this section is divided by vein in situ veins, which veins are repaired in their original place or other than the vein. Bypass graft by vein. You're going to code by the type of graft and vessels being used to bypass. In the example 35506, a bypass graft with vein of the carotid subclavian or the subclavian carotid. The graft is attached to the carotid and to the subclavian, bypassing a defect of the subclavian. Your vascular injection procedures, 36000 to 36522. Again, this section is divided into intravenous, intraarterial, or intra-aortic, or venous. This section is used for many procedures, includes local anesthesia, introduction of a needle, a catheter, and it may be used for injection of contrast material and also used in pre- and post-operative care. The example here is an injection of an opaque substance for venography. Your transcatheter procedures, 37184 to 37216. You may find an arterial mechanical thrombectomy in this section, which is a removal of arterial thrombus by a mechanical device. There are add-on codes, which are used to report a variety of transcatheter procedures. The venous mechanical thrombectomy is 37187 or 188, and this is removal of a venous thrombus by means of a mechanical device. So now we're going to talk about the cardiovascular procedures that you may find in your medicine section. Your medicine section is going to be right behind the 8000, which is your path and lab, in the back of your CPT book. And remember I told you this is kind of like a catch-all section. You're going to find cardiology. You're going to find all kind of stuff here. Your physical therapy, your what other codes are back here? Your CABG, some of your CABG codes, your EKGs and things like that. Those are all going to be in this section. In this section, though, services can be, again, invasive or non-invasive, diagnostic, or therapeutic. Your subheadings for your cardiovascular procedures are going to be therapeutic services and procedures, cardiography or echocardiography. So just take a few minutes and go to that section and see if you can find those subheadings. Again, here you're going to find your cardiac cath, your EP procedures and studies, your peripheral arterial disease rehab codes, non-invasive physiologic studies and procedures, and other procedures. So your therapeutic cardiology procedures, your range of codes are going to be 92950 to 92998. Types of services in this section are your cardioversions, your infusions, catheter placement, and thrombolysis. Many of the groups are divided by the method, location, or number. So was it done by balloon or blade? Location, was it the aortic valve or the mitral valve? How many were done? Was it single or multiple vessels? Here you will find your Holter monitor, your stress test. Your EKGs are going to be found in your cardiography section, 93000 to 93278. The different types of services here in this section, you might find your stress test and again your Holter monitors. There are separate codes for global procedure components. You want to see 93000, 93005, and 93010. And if I'm not mistaken, I'm not looking at my book right now, so I'm going from memory, but I believe these are your EKG codes with interpretation, without interpretation with the report, and so forth. Again, depending on what type of facility, if they own the equipment, the provider works for them, are basically going to be how you build those. This is just an example of what a Holter report would look like and what it's used for. It's used to identify cardiac arrhythmias. The patient usually keeps it on for 24 hours, and it predicts, it prints out this report, and the doctor reviews it and interprets that report. Your echocardiographies, our range of codes here are 93303 to 93350. These are non-invasive diagnostic procedures where they use ultrasound to detect the presence of cardiac or vascular disease. Your cardiac catheterization codes are used to identify valve disorders or abnormal blood flow. Your range of codes here are 93501 to 93572. There are a lot of bundled services in these catheterization codes. So any introduction, positioning, repositioning of the catheter, pressure readings, blood samples, rest or exercise studies, and even the eval and report. These are all these things here are included with that code, and you would not code them separately. A lot of the codes here are modifier 51 exempt. There are 3 components of coding cardiac catheterization. The first, the placement of the catheter, where was it placed, the injection, and the imaging, supervision, and interpretation and report. Intracoronary brachytherapy. This is a new procedure that uses radioactive substances to destroy restenosis of a coronary vessel. Patients have had stents placed in a coronary vessel. A stent or restenosis is a reformation of plaque. The cardiologist will probably place the guide wire and the catheter, and then a radiation oncologist will place the radioactive elements. So you'll probably have, two separate bills from each provider. Intracardiac EP procedures and studies, your range of codes here, 93600 to 93662. Again, this is the EP system of the heart. Here is where you would find the electro recording codes divided or based on the location of the recording device. Was it placed in the bundle of his or the right ventricle? And the pacing, temporary pacing to stabilize the beating of the heart. Example here is intraventricular or intra-arterial pacing. In this section are basically services to diagnose and treat conditions of the electrical system of the heart. And then you have kind of a diaphragm here as well. PAD rehabilitation, 93668. This is a rehab section for someone with this disease, and it normally lasts from 45 to 60 minutes. They use maybe the use of a motorized treadmill or track built to the patient's cardiovascular endurance. It is usually supervised by an exercise physiologist or a nurse. Some of your non-invasive physiologic studies and procedures, your range of codes here are 93701 to 93790. This category contains codes for services such as a plethysmography, which is the recording of the changes in the size of a body part when the blood passes through it. Electronic analysis will check electronic function of devices such as your pacemakers. Your ambulatory blood pressure monitoring, again, it's normally done on an outpatient basis over a 24-hour period. I'm sorry, guys, I went too fast. And either a thermogram, which is a visual recording of the temperature of the body. Now I can go next one. So cardiovascular in your radiology section. So there was a major revision done in 1992. It is divided into two components, the technical component and the professional component. If you go to the radiology section, you will see a section for heart and aorta artery subsections. Here you may find your angiography. The technical component, which is the use of the equipment, remains in the radiology section, but the professional component, which is the injection, that is in your surgery section. Prior to 1992, the radiology section contained codes for all the cardiovascular procedures. Complete angiography requires a radiology code and a surgery code. Reflects common practice of cardiologists performing the injection and the radiologist performing the angiograph. Often radiologic procedures use contrast material to improve the image. So many of the codes have contrast material bundled into the service. It'll say with contrast, with or without contrast. Only injected contrast qualifies. Contrast that is not included in the description and is used in the procedure, code both for the contrast material and the injection separately. So here's an example. Two physicians, a cardiologist and a radiologist from the same facility, perform an angiography of the third order of the brachiocephalic artery with contrast. The cardiologist placed the catheter, which is 36217, out of your surgery section. And then your radiologist performed the angiograph, which is 75658, out of your radiology section. And then the supply of contrast material, you would code 99070 from your medicine section. So as you can see, there are some procedures, and normally it is really only your cardiac cath that you're really going to have codes or your angiographs from all three sections. You may not have all three, but 9 times out of 10 you will if you're doing cardiac caths or angiographs. So that again concludes this module. Again, I know cardiology, there's a lot. Again, kind of go back, re-listen to your to the lecture tonight. Study your handout. There's going to be some practicals in the class marker for you to practice on. We're going to do a lot of cardiology practice. However, you will not get interventional radiology or complex heart procedures on your certification exam, and you probably won't code them unless you're working in a cardiology office. Some of the common procedures you're going to code are, well, actually cardiac caths are very common. They do them on an outpatient basis, so you may use that quite a bit. EKGs, of course, you're going to use. Holter monitors, you may use pacemakers. It's a pretty common procedure. People are getting them placed, getting their leads replaced. So there's only a few procedures that you may see on a regular basis. Outside of like a cardiology specialist, like if you're doing outpatient coding for a facility or same-day surgery coding for a facility, you may see some of these. But usually the interventional, where they're talking about the third order, that's called interventional radiology. And again, there's usually coders that have been trained and specialized to code those. And so, because they're very complex to code. So don't worry about, all of that. You won't have to, necessarily remember all the arteries and the branch and how to code those on your certification. But now that you are familiar what type of procedures and how they are performed. So that concludes this module. Again, go to class marker. There will be some practicals there as well, and we will do a class practical. Please print that out. You can attempt to do the class practical. However, we will look at the class practical in class next week. Happy coding!